Good morning, everyone. I'm glad to sit here and give you a short speech. My name is Liu Tonghanyu. I'm a doctor and I graduated from Tonghanyu University. Today, I'm going to present the paper titled Coronary Intravascular Imaging and Physiological Function for Optimization of Percutaneous Coronary Intervention. First of all, let's have a look at the limitation of angiography. The figure above tells us the degree of angiographic narrowing, and some features of coronary lesion may not be reflected by angiography, so that we require AVAS or OCT to evaluate further. And now I'd like to move on to the AVAS. It is based on acoustic reflections. Due to its much power of penetration, we can detect external elastic membrane, image plexus, and also tissue characteristics. Let me give you some examples to understand the role of IVOS in clinical practice. First, we can see the top angiogram shows only minor luminal irregularities, two sites in left anterior descending artery. The arrows show major atherosclerosis by IVOS. Entire vessel was diffusely diseased. So the extent and severity of disease by angiography and IVOS are frequently discrepant, and that leads to the angiographic underestimation of disease. Here's an example of coronary remodeling. The angiogram is completely normal, but two sites in left anterior artery, the arrows show a very extent of atherosclerosis by IVOS. More distal site, the top right, has little disease, but more proximal site, the bottom right, has a large crescentic atheroma. The lumen size at both sides is similar because of remodeling, resulting in a false negative angiogram. This graph shows you the stenosis with negative remodeling. A distal reference segment, the gray arrow on left, has EEM area of 16.4 square millimeters. Stenosis, the black arrow on left, has EEM area of 13.9 square millimeters, demonstrating that it is partly due to the negative remodeling. A recent meta-analysis, including time randomized controlled trials, showed benefits of AVOS-guided PCI for the decrease of heart outcomes, including cardiovascular mortality, myocardial infarction, target lesion revascularization, and stent thrombosis. As we know, IVOS is often used in left-leaning coronary lesions and bifurcation lesions. When confronted with short, soup-like LMCA-based diffuse, eccentric nature following the unusual course, IVOS could reduce the risk of an inappropriate decision for coronary artery bypass graft therapy. From the final interpretation of angiography that was overestimated or underestimated. Median classification has been widely adopted from angiographic perspective in bifurcation lesions. The AVOS in lesions bifurcated at pre-PCI is able to describe the traits of coronary culprit in detail, particularly associated with the side branch, making appropriate decisions for coronary revascularization possible. At post-PCI, IVOS helps to evaluate stent malposition under expansion and dissections, especially near the opening of side branch, which may benefit future effects. I'd like you to look at these figures. The left figure shows the patient with ICAD who has normal angiogram. In OCT, external elastic lamina is poorly visualized. In IVOS, intramural hematoma with homogeneous and heterogeneous content. We can notice the three-layer membrane overlying the false lumen and complete visualization of the external elastic lamina. The right figure shows representative intracoronary images from different patients. For OCT, In image A, double lumen with a thick intima-meatal membrane. In image B, double lumen with a thin intimal membrane. Image C, intimal rupture, aerosol. Image D, intracoronary thrombus protruding to the true lumen. For avus, image E, elliptical echogenic true lumen fully detached from the outer vessel wall. Image F, double lumen with a side branch emerging from the true lumen. Image G, double lumen with a false lumen thrombosis. Image H, intramural hematoma. Notice the three-layer appearance of the intima-meatal membrane and the layer crescent-shaped intramural hematoma. Overall, different intravascular imaging can lead us to detect different findings. Now, let's move on to OCT. Illumine-1 study showed that doctor decision-making and PCI planning were influenced by OCT results, both before or after PCI. OCT was consistent with IVUS from Illumine-2 study in stent expansion and was in line with IVUS from Illumine-3 study in minimum stent area. Doctor study confirmed doctor decision-making was rightly influenced by OCT readings, bringing about a remarkable change in procedural strategy for PCI. Let's turn our attention to calcified lesions. IVUS can measure lesion calcium, most often is superficial, cannot detect deep thickness or mass. But for calcified nodule containing large areas of calcification can be detected in atherosclerotic lesions, characteristic of atherosclerotic and hill nature, such as acute thrombi. It is uncommon but can cause severe lesions of calcification in ACS patients. An analysis ACS patients underwent pre-PCI using OCT. Most lesions had a calcified nodule. OCT may serve as a significant index of stent expanding after implanting drug-eluting stent. Stent under expansion poses a grave risk to stent-associated restenosis and thrombosis. Practical guidelines recommend using rotational atherectomy for complicated calcified lesions that fail to pass through by balloon or dilate sufficiently before implanting drug-eluting stent. An interesting example of erosion study illustrated such thrombus can be disappeared after antithrombotic therapies. OCT showed a progressive decrease in the quantity of thrombus from a follow-up 1 year later. Except for coronary intravascular imaging, we also pay much attention on coronary physiological function, for example, FFR. So far, pressure-derived hemodynamic assessment is the gold standard for deferring revascularization in patients with non-LMCA stable coronary artery disease. For left main coronary artery lesions, we usually combine IVUS or OCT to measure the minimal lumen area. Then we proceeded in necessity to next physiological function assessment. The evidence demonstrated that FFR less than 0.75 was in relation to excellent prognostic effects compared with the deferred PCI. The lower the cutoff value of FFR, the worse the incidence of MACE in deferred lesions. IVUS, OCT, and FFR are the main intracoronary examination modalities for implantation of coronary stent nowadays in the cardiac catheterization laboratory. However, there are still several problems, especially in underdeveloped countries. Evidence from a survey in various countries showed that several elements causing the low utility for intravascular imaging modalities were recognized. That is, high cost, prolongation of the diagnostic procedure or intervention, reimbursement issues. lack of training for use and interpretation of these modalities, absence of established criterion for corrective measures based on abnormal imaging findings, risk of procedural complications, clinical value is not established, or other factors. So, the precise PCI has a long way to go. But currently, some novel modalities, for example, artificial intelligence that combine with multi-intravascular modalities, anatomical evaluation, and ischemic evaluation are on the way to precise PCI. Let's take the case of feasible AI-based FFR algorithm, AutoCAD FFR. AI-based detection of lesions proved a conspicuous success in almost 100 lesions with FFR less than 0.8, which presents a good sensitivity and specificity. Another novel AI framework from 5 international centers using deep convolutional network for OCT plaque characterization was developed, showing a good diagnostic accuracy in the lesions of fibrous plaque, lipid, and calcium respectively. Thus, we look forward to the evolving future of AI for precision therapy of PCI guided by intracoronary imaging. Apart from this paper and in my spare time, I looked up the information about the number of tools in official website. After analysis, the distribution of coronary intravascular imaging and physiological function in China, to some extent, told us not every hospital used all types. Present intracoronary technical characteristics and clinical application have a lot to be learned. This brings me to the end of my presentation. Thank you.